Right, now we're going to continue. I'd forgotten my notes. But this is a very original theme because we're going to ask the industrialists to give us their vision on how they could build a fair health system. And we have Michel Chekroun, Patrick Erard, Pierre Laurent, and Philippe Cheng. And François Sarkozy is going to be the moderator for this debate. So over to you. Good afternoon, everybody. Thank you very much indeed for having invited us. We are very happy to be here. The time frame is a little more difficult for me today, and there are a lot of men here this year, but I'm sure we'll manage. This is an interesting theme. The theme is fair health system, and the industrialists have been asked questions that they're not generally asked. There's one person in the public that must be studied closely, and it's the subject of equality. Every time we propose a differentiated approach according to the patient's profile, in France we say, well, it's not possible. In France, everybody gets treated the same way. And it doesn't seem to resist the arguments, because I think that we're going to have to do more for those who don't have much today. The first issue we're going to take a look at is, as industrialists, do you find this system fair? If it's not, what's not fair? And what do we have to reinvent to govern it differently? And to do this, we have quite a lot of devil's advocates. They're industrialists, and they going to discuss a very interesting subject. We have Patrick Erard, who's president of LEM in France. And if you'll allow me, he has a very ethic approach, and he's also a writer. What's interesting is that we're going to have a philosophical debate with Pierre Laurent, who's president of the steering committee and founder of Volontis. Michel Chekroun, who's president and founder of Carinity, which is a platform an online platform. Then we've got my friend Philippe Cheng, who's vice president of Sanofi, and he's also administrator of LEM. But we're going to launch the debate. And perhaps we should start with you, Patrick. What's your feeling about the health system? Is it fair, structurally speaking, in terms of the resources it uses? What do you think? Well, I'd like to start with a preliminary comment. This evening we have a debate on the subject of fairness, and we've substituted the term unfairness for fairness for some reason. Human nature is such that everything's unequal by nature. Fairness is something that counterbalances a natural inequality. And in the health system in particular, the right issue to raise is that we should have a fair system despite the inequalities, and that everybody has a fair chance to get health care. The preliminary remark that I wanted to make was this is a question for the rich people, because if you think about it for a couple of minutes, when you're in the Sahel or Africa, or if you're in some of the parts of China or other countries that are now third world countries, the problem of fairness just doesn't even exist, because there is no system that enables you to raise the issue. So I think you've got to be aware of the fact that unfairness and fairness is something which it pertains to the rich countries to start with. But the wealth of countries such as France raises the issue of three aspects. The first is the structural aspect, the second is the cultural aspect, and the third is the social aspect. And the structural aspect is very simple. It's just the grid of healthcare. Hospitals were built after the Second World War and between the two wars in some cases. And a hospital had to be as close as possible to where you lived. And the more hospitals you built, the better the population was going to be. That sounds very basic. Everybody was going to easily have access to local health care. And the same was true for GPs and doctors across France. But the problem is that technology has moved forward, and this mesh, which is extremely tight, is now becoming unfair for a simple reason, because we can't technically equip all of those hospitals and all those doctors with the same technology and of the same standard. So with the progress of technology, we've created something unfair, which is the incapacity of superposing these new technologies to the basic mesh we had beforehand. So we've got a system that is now unfair, that we've imposed upon the population. Culturally speaking, there again, it's an issue that pertains to the rich people, because you have people who are higher on the social cultural level, others who are down the ladder because they're immigrants. You attract people from other cultures, and thus the cultural wealth means that you've got a certain inequality in the way you actually comply with the treatment and understand it. And I have a common point with Philippe over there, because I work in 9-3, as it's called, in Saint-Denis. And I cared for people from all the different levels over the years. And I can see to what extent this unfairness, this natural unfairness, and the capacity to understand and comply with the treatment leads to this unequal footing. And lastly, you've got the difference that there is between the way the system is funded and the economic problems we have today, which by definition are going to affect the concept of choice. And there again, there's a certain inequality, but because you can't necessarily choose what you want to choose. So there are three sources of unfairness in these rich countries. Well, what one could say by reducing the argument is that progress may, in fact, increase the gap. Well, I'd like to know what the patients on your platform say. What do the patients think about this healthcare system? And what do they think about the gap? Do they think that it's getting bigger, or do they think that new technologies are contributing to making it smaller? Well, since this morning, we've been talking about unequal access to healthcare. But I think we've got to talk about unequal access to information. And that's what the unequal access to care is due to. That's based on communication, which is a lever for democratizing health information. I heard from people this morning that said it's much better to. I heard somebody saying that it's better to have a brother-in-law who's a doctor if you've got a problem, rather than being out there in the country with very little contact with a hospital. We've got internet too, that is the second largest source of information for patients today. I didn't say that. It's a study done by the Order of Doctors in 2010. And with all the people who have access to internet, 7 out of 10 people are registered with social networks. And what we see today is that French people are looking for information. Patients look for information, exchange their experience with other patients concerned by the same issues. So what do the patients do? Let's not forget the family. The patients can play a very big role in information, especially for the elderly or for children who don't have access to that information. People go onto internet and get information and practical hints from other patients, what I call real-life information, typically on issues such as how to react to a symptom or if your condition develops. And a lot of patients prepare their consultation before they go and see the doctor on internet. 4 out of 5 people, before they go and see the doctor, go on to Dr. Google and take a look to get as much information as possible. And quite a lot of them go and check out and challenge the doctor's prescription once they get back home.
So I think this is a movement that's inevitable. It has led to a lot of profane or non-medical knowledge. It's the patient's knowledge, and he will compare it with the doctor's knowledge. Now, in terms of treatment, do the patients complain about unfair treatment or unfair access to care in different areas of France? What do they talk about on these forums? Well, they talk about their own experience, yes, with their own doctor. We see this in particular in patient communities such as psoriasis or bipolar disorders or diabetes patients, people who have seen a doctor once, a specialist once, and they have proposed an appointment 6 months later, for example. And so people often abandon or stop adhering to their treatment. This is often quite frequent with pathologies such as mental health issues or certain dermatological diseases. And patients exchange about their own experience on the social networks without finding solutions, or they ask for practical advice from other patients who are experiencing the same problems in their same territory, and they ask for doctors' names, for example. Well, I'd like to know what the healthcare professionals think about this, because people in the industrial world, and Philippe, you're replacing Antonio Tatanoro, who was also held up with the Air France strike. He's stuck in China. But now what do the healthcare professionals think about this? Are they a bit lost? Because we have the impression, and we heard this earlier, the difference in access to different networks. Patients are now more informed. They're changing. There are new technologies. There are new treatments. All of this has to be updated. What do the doctors think about this? Well, first, let me continue to reinforce the position of the industrialists with the people at the round table. Yes, rapidly. I think to build a healthcare system that is fair, there are 3 steps. First of all, access to healthcare requires education in school. We haven't talked much about education here, but hygiene we did talk about with this fascinating debate on water. Vaccination for small children. There's a whole range of aspects that are becoming more fragile. There's a real polemic around vaccination, for example, and this fragilizes this essential foundation of access to healthcare. Access to healthcare is a real problem we see in Africa in the disastrous situation of epidemics, and we don't encounter this problem in Europe and in France to such an extent. And there's also the problem of access to healthcare products and services. And here I'm being very broad. Here, this is more the technological aspect, but I think we can no longer separate it. It's no longer a drug that arrives by itself. Very often there are integrated therapeutic strategies that can simplify things, but can sometimes complexify things in terms of assessment, because today no one really knows how to deal with these technological innovations. Often they are assessed in pieces. This is the case of biomarkers, of companion tests, where it's a little bit difficult to have a consistent assessment. Now, in France, to answer your question, we had fascinating work that was done in 2011 with doctors, elected officials, national representatives, members of parliament, senators, local officials, people in charge of regional health observatories, people in charge of the regional health agencies, and this led to the publication of a book by Emmanuel Vigneron on healthcare inequalities in the French territory. What's interesting here is that the subtitle of the book was Taking Stock and How to Make Progress. So mapping the problems is useful, but then we need to set objectives. There were 26 recommendations in this book in 2011, and unfortunately, none of them have been truly implemented, I'm afraid. And I don't think we will be seeing them implemented anytime soon. On page 83, for example, of this atlas, there was the map that was referred to by Claude Evin this morning of the RER-B line that crosses Paris, where there's a huge north-south line. And do you know where the mortality peak is? I'm asking the questions now. The mortality peak is located around the French Stadium station. And what is there around there? There's the Biomedicine Agency, OFS. All types of healthcare agencies are located at that subway station. So it's an extremely difficult territory, and we've both worked in a hospital there. So I think the situation is getting worse under economic effects. Let's go back just for a second. Our healthcare professionals, when we talk about fairness, this would mean a differentiated approach depending on the person you have across from you. You have to adapt your message, adapt your tools, adapt your communication to do so. Maybe first we should take a look at new technologies, and then we'll come back to discuss this again. That'll give me maybe some new questions. Pierre, can you say that new technologies are truly a tool to reduce these inequalities when we're far from an expert center or a healthcare professional? Or will these tools reinforce inequalities because people need to have the necessary resources to invest in them? Well, let me testify about the experience developing a new arrival in our, which are what we call software, therapeutic companion software, which complete treatment to allow a patient having access to mobile or web technologies to be closer to his healthcare team, and to have daily tools to help him follow his treatment, whether it's to manage adverse effects, to manage the dosages of a drug, and to be in a close relationship with his healthcare team. So there are different situations that we've developed in different medical sectors. One very well-known application for diabetes, for patients to really draw a maximum benefit from their treatment when they're treated with insulin. And the patients are not uniform. Some patients draw great benefit and become more independent in adhering to their treatment, and they're not asking for more links on a daily basis with their caregivers. And other patients are perhaps not using the solutions so much on a daily basis, but they really appreciate the fact that these tools do allow them to remain in contact with the medical team who can intervene thanks to the data that we've been talking about since this morning, these data which are so central to this type of system. Another example, with a rare disease, we work with hemophilia, and in this context, we have a population widely distributed over the territory, and there are expert centers, reference centers that are there are only a few in France. And this technology allows the patients to be closer to the specialist doctors who are experts in the disease without having to drive hundreds of miles to reach these centers. So these tools are now in everyone's pocket, and they will allow people to become closer to the medical teams and also multiply the impact of a healthcare professional on many patients. For example, concerning insulin doses on a daily basis, we now have algorithms. We haven't talked about these so much, but these are medical algorithms to extend the medical decision to become closer to the patient. So these new frontiers of personalized medicine with these companion software programs, they're quite synergetic with the drugs, and they will help boost the performance of these new therapeutic treatments. Well, you've emphasized here that the results are heterogeneous according to the patients. Perhaps there's a bias in your tools. Perhaps you, Corenity or Voluntis, I know that on the internet you said that 83% of the French are connected, but in the end, to come back to the point emphasized by Patrick, aren't we completely ignoring certain people who don't have the means to understand or access these new technologies? And this was Patrick's point. Aren't we reinforcing this gap? Well, two answers here on my part. Yes, indeed, we're concentrating a lot of our developments on the smartphone, which is a very interesting vector to develop these solutions for patients in wherever they are at whatever time of day. We also see that in certain medical sectors, it's very interesting to work with a very broad approach in terms of communication channels. Today, even if mobility is important, let me give you an example. We're working in the US to track anti-vitamin K treatments for elderly patients. They don't necessarily have a phone in the pocket, so we provide other types of access to the solution. It can be the web, it can be an interactive vocal server, it can be their self-measurement device which communicates to send the data remotely, or a call center. So we do adapt the communication channel to the patient. That's the first comment. Let me give you a second example. Not in Western countries, but we're working in a developing country. And in this country, we've realized that with diagnosis tests, these new technologies allow us to carry out rapid diagnosis for a cost that's more and more attractive. So here we see that we succeed in ensuring that these solutions are truly effective for massive application, including in countries that are not considered rich today. This is a new aspect of these technologies, and we will be able to, for under 10 euros, do a complete diagnosis of certain parameters without having to have people go to a laboratory. So you're saying that these technologies allow potentially to reinforce the link between the different players, the doctor, the patient, and others. But let me come back to my question, and Patrick and Philip, I'd like you to answer this question. In our healthcare system, we have actors. We talked a lot about this morning, and we won't come back to the topics and the comments that were made in the first roundtable. But how do the healthcare professionals feel about this between the patients that are more and more informed, the new technologies? We have a feeling that we have new patients who sometimes consider that the doctor is only a single source, one source of information among others, and the patient's going to make his own opinion. How do the healthcare professionals experience this? Are they ready? Is there perhaps some training necessary, some awareness raising required? Yes, certainly. You can just look around you when you're working in the medical world and see the extraordinary heterogeneity of doctors. Some announce a very serious diagnosis, and the way they take the time to bring their patient and to provide support and to make their patient take ownership of his own therapy. And you can see the very worst examples and the very best. And I think when I was a medical student and Philip was a medical student, I think we were at a level 0 in our days. And in reality, there's no training, philosophical or psychological or social training in medical school, which means that this very special dialogue between the doctor and the patient is something that's absolutely not studied or taught well. And the arrival of these new technologies, so access to information, but also telemedicine, the fact that the patient can interact with the doctor virtually, doesn't solve the problem from this standpoint, because nothing will replace the humanistic human approach in therapy and in the way you support the therapy with your patient. And to answer your question, I think many doctors are not ready just because they haven't been prepared. Can I answer your question as well? Just a comment. I have the feeling, when I listen to all of the discussions since this morning, that we are facing something that's quite brutal, where we're reversing the symmetry of information. In the previous decades, the doctor was the person who had the knowledge, and now the patient arrives with a mass of data, a mass of knowledge that he brings to the doctor. And so there's a real reversal of this information symmetry, and we're coming back to the debate that we had earlier. How can we have open information but still control it and make sure that it's of good quality? And that's where the debate lies. And it's this abrupt reversal that creates a lot of tension, I think. You mean for people in industry, you need to change your client targets or the correspondents with whom you work due to all of this? Your stakeholders? Yes, this is what we want to do. Unfortunately, regulations are going in the opposite direction. The regulations are moving us away from therapeutic education of patients. And I think that's a terrible mistake, because if we don't contribute, we can't do it alone, of course, but I think there will be a lack of education, a real deficit. We see this with the problem of tobacco and education concerning diabetes, all of these subjects concerning nutrition as well, all of these educational subjects, as Philippe reminded us, concerning vaccination. How many of you in this room are up to date with your tetanus vaccination? And you can even prick your finger when you're gardening. So we have an educational problem. That means we don't fight for prevention enough. And we in industry focus too much on the role as the therapeutic role of the drugs that we put on the market, where we should be acting upstream on therapeutic education. Now, this new system that you really would like to see, an approach more patient-focused, taking into account the patient profile and different technologies, wouldn't this impact the modes of financing and also modes of remuneration? Should this impact the remuneration mode? We talked about outcome-based measurement, and I thought these comments were very interesting. Is this going to impact remuneration modes, either of the different actors or of healthcare products? Are you ready to see things change? This was said earlier, I think, if I remember, by Frédéric Chassagnol, that this quote-unquote personalized medicine will allow us to keep the value created for a specific type of patient. And we could speak of outcome-based performance and remuneration, and this could also cause things to change quite a bit. Well, this is already a very topical subject. I think you hear this a lot today. Everyone knows that it's a very topical idea to apply pharmacists to vaccination questions and involve them. Certainly, there's an overload of work for doctors in rural areas. Why not give pharmacists this preventive role in vaccination, for example? This would be a way to respond to the question, to perhaps delegate progressively a certain number of medical acts and paramedical acts to a broader healthcare fabric, and we could remunerate this or think of some kind of advantage that could be deducted. And then we should ask ourselves the question with these new technologies, which should be promoted. So remuneration of healthcare professionals, there's no doubt that their structures will be changing, especially due to the arrival of these new types of treatment which integrate telemedicine. Today, healthcare professionals don't receive adapted remuneration when they're treating their patients remotely, for example. There's not enough incentive. We discuss this regularly with the payers, the paying bodies, to see how we could change these remuneration modes. we need to address the subject of potential abuse. And of course, then we will have to look at some kind of lump sum system where we would have a lump sum payment for professionals involved in treating a chronic patient. Solutions do exist to have reasonable solutions that would not be too expensive, that would allow us to accompany the patient more effectively than we do today, because a diabetic patient who sees his healthcare professional once every 3 months and then sometimes lacks motivation and stops adhering to treatment, we see that there are some real gaps here. And this would be a moment where we need to intervene to re-inject time and for a more global care management. Many people here have many of these ideas have come out of the hospital world, but if we want this to be widespread in the private sector, we need to work more on primary care. And we see that the private sector doctors can only be involved in this type of remote treatment if there is a fair payment for these types of acts. And we see that there are actually new roles in healthcare journeys. For example, there are telemedicine nurses now who have a role to extending the doctor's role in terms of telesupervision, telemonitoring. And these actors will all have to be properly remunerated. And they will have roles that will be more and more delegated to them. And the quality of treatment of chronic disease will require treatment with a team that is properly remunerated.
It's also going to have an effect on the remuneration of companies, and I know we'll be talking about that. So, therapies are going to be broader. If you look at a medical device, there's going to be another solution that's going to increase the value proposition, and because of that, the value will increase. There are other examples, because in some countries, let's take the United States, for example, paying authorities, treatment is reimbursed in terms of their real-life performance. So objectifying real performance needs real data. For anticoagulant-based treatment in that specific context, for example, the leaders are only reimbursed if patients go through a series of self-monitoring tests, and if they don't do that, there's no reimbursement. So it's something that is specific to certain contexts in some countries for the moment, but it does get us to think about how we're going to be remunerating the performance of healthcare products in the future. Now, patients, are they talking about that on your platforms? You've got a platform, and you can see what they say. Are they aware that in some cases, the remuneration methods may be an obstacle to access to best of care? There's the link via the hospital as well. Sometimes you don't have the right incentives. Well, patients today are aware of a certain number of things, but when you talk about performance-based remuneration, the link with outcome is, of course, essential here. We've been talking about outcome and medical results that have an impact on patients. We've talked about integrated solutions, but I'd like to talk about patient insight as well. Today, it's data that is underexploited. The most underexploited data in the system, moreover. So patients, patient insight, patients who take part in studies or are on platforms, collaborative platforms, with or without patients' associations. And we're realizing today that in this integrated solution approach proposed by drug companies, there is a step missing, and that step is a kind of segmentation of patients according to standard profiles. I think today we have a fairly normative approach, if not dogmatic approach to patients. There isn't just one patient, there are lots of patients. 3.5 diabetics in France. there are probably as many expectations, as many needs as there are patients, and as many treatments and approaches. There are the notions of comorbidity, co-treatment. I won't go into details about those, but today we do have the means. Those of us who are involved with new technologies, we have the means of facilitating that segmentation. We can produce objective data like sex and age, geographic area, the history of the patient in terms of medical products taken. We can also look into fears, hopes, motivational factors in relation to the patients complying with their treatment. And before thinking about medicine based on performance, let's listen to those patients. Let's listen to what they have to say and what patients' associations have to say. And I'd like to use the English word profiling of patients. That's what we need to adapt solutions. So I think we have an agreement here. It's a key success factor, recognizing the profile of the patient, not just thinking of the patient in terms of their condition. Now, I have a joker that I'd like to play now, Didier Bazuki. I'm going to get him to contribute now. So thank you, Guy. I know that we have to stick to the timing, but I'm allowed to talk to him. So we've got a payer around the table. There are things that are being set up. This is what we've seen over the course of the past few weeks. Additional insurance companies. Let me summarize. So we can provide a bonus for virtuous behaviors. If you have this bonus, things will cost less. So what do you think about that idea? We've talked about differentiation. So that seems diabolical to me. Why? Well, Guy's going to be happy about that, yes. I think we have to say things clearly. If we want a fairer system, a system that distributes resources to people who need them, we need to go right through to the end. We need to look at everything. We need to take into account the human dimension, as we've already said that. We need to look at the medical condition of the patient. When we set up sensors without wondering about the personal situation of the patient, their ability to stick to the specifications that have been outlined for them, and the advantages, the benefits that may become determining factors in terms of bonuses or guarantees, we create a situation that is not fair. Yes, so again, what you're saying is that it's how you go about these things. Yes, obviously. And now other approaches can, of course, generate fairness. Let me take an example that is fairly old in telemedicine, but it's interesting from a point of view of health economics and from an industrial point of view as well. A few years ago, the Danes, to make savings, launched a telemedicine process in lung speciality. So doctors went off with their video conferences, with their spirometers and their different sensors, and the patient went off home with their case and with the different pieces of equipment. And this meant that the patient felt safer, their comfort was improved, and it was a very fair approach in terms of distributing resources. So there wasn't a purely financial objective, and that's what was good about it. And then there is another industrial challenge that we need to talk about in terms of connected objects. In Europe, if we don't seize these kinds of opportunities, they will emerge elsewhere. So I think from an industrial point of view, we need to focus on these connected technologies to keep patients at home. We need to have the right kind of favorable legislative framework. In California, when a startup is launched, the government ignores regulations for up to 3 years. So that's not French, is it? No, that's very American. But it's ideal if you want to create companies. So there are young entrepreneurs here that sometimes have to battle regulations. So we mustn't have over-regulation. We must make sure that regulations can be adapted so that industries can emerge. So it's this new medicine based on technology that is important. It must be part of the framework, and it must be part of the laws in France. Thank you very much. Again, as usual, it was very interesting. We've heard lots of interesting things, but I don't think we can talk about all of this without talking about the price of drugs. We talked about this in the previous debate. In France, we have a system that is such that when it's accepted, even if it's a difficult battle, and I hope that you'll forgive me saying this, but in France, in other countries like the United States, because everything's paid out of the pocket, people pay with their own money, there are certain populations that never, ever have access to that. So it's really not fair, is it? Now, it's not because of the drug companies. Your answer is in the question, Francois. The question is good, but it's not the right question. The real question, so you don't want to ask that question, is that right? No, the question is, and the example that you've taken really demonstrates it. The question is that of financing of our system and the way our system is structured. We have to put the church in the middle of the village, as they say in French. So it's part of our mission, my mission, to think about regulation and regulating the price of some kind of innovative breakthrough. This is something that we have to think about in-house, so to speak. But the problem is to see what the financing need of a country like France is, and how do you structure that financing? What about the evolution of technology, the evolution in medication? What are the trends? What do we have to do in order to finance that? Even the health department knows how to answer that question. It's at least 6 or 7% growth. At the same time, the Parliament's saying that changes to health expenditure need to be stable, zero, basically. So there's something wrong there. It's an absolute contradiction between the supply and demand. Now, what do we sit the system on? You took the example of the United States. You sit the system, you base the system on the system of financing on citizens. In France, we are lucky enough to have a pooling of risks, a pooling of financing. But the problem is that the foundation came back after the wars. And it was at a time when there was economic growth and a lot of work available. So employees paid into the social security department coffers. Now, many companies are going bankrupt, so the foundations are crumbling. So what do? Well, how do we make savings? That's what we've been thinking about, but that's not what we should be doing, really. We're on the wrong track. The real subject is how do you reform the efficiency of this and how do you make it profitable? How do you make it efficient? This is what Eric Bazillac said earlier on. The right use of care for the best cost. That's the real question, and what a lot of waste in this country. I was talking about hospitals earlier on. When are we going to be courageous, be audacious, and reform the hospital system in France? And secondly, how do you found a financing system for health insurance based on anything else, based on something that is not going bankrupt? That's the problem. Before asking the right question of the cost of medication, the cost of drugs, that's the question that we need to be thinking about. So the debate's wrong, and the next generation and the generation after that will have to bear the weight of our stupidity. So can we have your recommendations, the three of you? Well, I agree with Patrick 100%. And I'm going to go a little bit further. I'm sure we'll be in agreement with it. As companies, we do have proposals that we would like to make. We're not fighting to preserve what already exists. We have proposals, some very concrete proposals that we can make. We can inject efficiency into the system. We were talking about integrated coverage systems. We're carrying out studies to look at regulations, but also to show that we can save money in terms of expenditure. And that's something that needs to be underlined. And we haven't talked about generics today. We were very much behind in terms of generics in France. And now with the ingeniousness of the CNAM, we've managed to catch up on that lag. But France is now at the same level as others. We've got efficiency in terms of healthcare expenditure. And that should let different margins emerge. Where a European country where the medication rate is low. Now, there's a kind of paralysis that I can see that we don't really understand. Self-medication is something that frightens people. There haven't been any disasters because of self-medication, especially major categories of medications. Medications that don't require consultation, that is. So self-medication has developed around these kinds of products that are available. We've been talking about self-medication, responsible self-medication, fail-safe self-medication. That's absolutely essential. But we can make savings in the system thanks to this. And then there are other savings that can be made in the system as well. So what we've said is that we need a system that's efficient, the right kind of use. We need to recognize the right patients. We need to find the right kind of solutions. We need to use new technologies, and we need to be inventive in terms of treatments. Pierre, we've talked about efficiency, but what about fairness, having something fairer, having the right technology for patients? Well, I'd like to make several remarks. Today, there are solutions that have been shown to be efficient, thanks to digital technology, for example. There aren't very many across the world, but let me give you an example. For mobile health, there's been an explosion of fitness and health applications. 100,000 applications have been identified in app stores. And so there are not even 100 that are considered to be medical devices because they do help patients to make decisions. Not even 30 have been proven to be clinically effective. So there's this bubbling of a whole lot of things, but there are a lot of gadgets as well, a lot of useless things. So we need to do some housework maybe. But there is something that can be explored, and that's the challenge, to identify the efficient, effective solutions that render medical services that need to be helped so that they access the market, including the refund market, if they have a value for the collective population. Why shouldn't they be part of the healthcare basket? Probably the patient very often buys these devices, but why not have some of them managed by the authority? So we need to identify these devices for patients and for health professionals. We need to focus on some of these solutions that have proved to be effective and efficient. Another comment, just to come back to what our friend was saying in terms of innovation. Today, we have solutions. We've got public powers that define refunding plans, and they try and reduce expenses. And at the same time, you've got the innovation amounts. But what do they actually amount to? Couldn't we make sure that we create future models and invest in those? In the telemedicine workshop, we were talking about the amounts allocated to telemedicine in France. 40 million euros a year, said the ministry. Let me calculate that. What does that mean? It's 0.001% of health expenditure today. So is that what it means to invest in the future? To invest in something that has potential for organizing healthcare in a very broad manner? Well, I would like, and this is very heartfelt, I would like to be able to make savings and in terms of the refunding system. I would like to invest in the future. I would like to test some models. I would like to see those being tested on a broader scale, because these technological innovations do offer a solution, one solution among many. But in terms of cost control, they do offer solutions. So we can understand we've got to have the right solution. We've got to identify the solutions. We've got to differentiate what might be taken over by coactivity. And then there's individual choice as well. What about the point of view of the industrialists, the companies listening to patients? What is their opinion? Well, my conclusion, I'm going to come back to patients once more. I'm sorry, it's an obsession. When we listen to patients attentively, and especially patients suffering from chronic diseases, of 14 million in France, 9 million on suffering from specific chronic diseases. Yes, the notion of price, the notion of who covers the costs, these are important. And on our platform, when we listen to patients, we realize that what they're talking about is not what they have to pay, but the impact of the treatment on the quality of their life. What information does the patient need at each stage of their treatment, as soon as the symptoms emerge, when the diagnosis is given, when the treatment is started? These are essential needs for patients. That this kind of information is hardly ever available. The doctor plays their role, but I think we need to focus more on prevention and compliance. This is something that we need to talk with companies and payers. Treatment as well. Access to treatment and availability of new treatments. There are many, many discussions on the platform, and not on just our platform, but on others, discussions about clinical trials, how to include the patient's voice in clinical trials, how to make sure that patients are involved in the design protocols, in the clinical trials, in the design studies. There are also discussions on why such and such treatment is available in Germany, but not in France. When Fompirac was launched, it's a treatment for multiple sclerosis, people in the Alsace were talking about this treatment with people who were on the other side of the border in Germany. Now, we need to look at that from a European point of view. Yes, absolutely. We need to listen to patients in order to better serve patients. Yes, in order to meet patients' needs better, keeping in mind that, there are lots of tools out there. There's no inequality in terms of listening to patients, apart from the ones who are not on the internet, but there are fewer and fewer of these people who don't have an access to internet. We could say maybe that the over 65s are the ones making most progress on social networks. We've gone from 6 to 9% in terms of rate of use. So it's not just for urban geeks, it's for everybody. When I hear today that patients are at the center of systems, I think that's a great idea. Okay, 3 concrete recommendations now that follow on from the LEM. I don't know if the minister is listening. The first is to make sure that we look at the hospital, not to dismantle it, but to make it more efficient. We need to focus technology and technical platforms. We need to pool them. We need to make sure they're excellent and uniform. We need to decentralize hospitality, so to speak, that has no added value as such. So we really need to look at hospital efficiency. Secondly, we need to educate the extremes of life, the young people. As soon as they're at school, they need to know how important it is to follow treatment properly. We need to educate older people, the third age, make sure that they're not taking too many drugs so that there's no terrible interactions between medications. So that comes in line with fairness. We need to also restructure the medical and economic evaluation system for our healthcare system. And of course, that includes drugs. We need to do something very simple there. We need to reason in terms of efficiency, in terms of productivity of healthcare, not in raw costs. And we need to stop the envelopes that were set, because that's not something that's going to help us be more efficient. It's a kind of binary bean counter attitude, and that's leading us to up the wrong path. Thank you very much. Thank you for your recommendations. So what I'm going to take away, and it's a common point for all of you, you're saying that we have to be audacious, we have to dare to do things differently, and even in France it's possible. Thank you.